All right, good afternoon, everyone. We'll go ahead and get started. Welcome to Medicine Grand Rounds. Good to see many of you here today, even with the mid-spring break season. It's nice to see a good turnout in person as well as online. And I hope some of you were able to take some time off to be with your family and loved ones as the season warms up. A few announcements. Next Wednesday, April 2nd, we will have the Charles Neff Lecture, which is hosted by the Division of Pulmonary Sciences and Critical Care Medicine. Our speaker for that lecture is Dr. Rachel Zemans from the University of Michigan. Actually, Rachel and I were both inducted into the ACI the same year, so I know her quite well. Her science is truly exceptional, and her talk is entitled New Paradigms in Lung Injury, Regeneration, and Fibrosis, so it will truly be very interesting. On April 9th, we will welcome two more of our chief medical residents, Drs. Nick Bianchina and Ali Fuhrer, to the podium for what I predict will be a controversial, exciting, and I hope interactive discussion, because their grand rounds is titled The White Coat, Why Some Wear Them, Why Some Don't, and Why It Matters. So I'm not giving you advice one way or the other, but you might want to wear your white coat for that one. Now, however, I'm delighted to introduce Dr. Mike Hollers, our speaker for today. Dr. Hollers is a Smith Professor of Rheumatology and Director of Faculty Ventures at CU Innovations, where he serves as liaison for faculty interested in moving their discoveries from academic to potential commercial ventures. He's a highly recognized academic physician scientist at Anschutz. The historical focus of his work has been on the structure, function, and biologic roles of the complement system. His lab performed the studies in which murine complement C3 receptors and membrane regulatory proteins were initially identified and characterized. Using tools developed through these studies, the in vivo pathogenic role of complement activation in murine models of human disease was demonstrated. These studies, in turn, were recognized with the 2008 American College of Rheumatology Distinguished Basic Investigator Award. His group then developed a novel tissue-directed complement therapeutic approach that has experimentally demonstrated substantial benefits over traditional strategies and is currently being tested in patients with renal diseases. Of more recent import, Dr. Hollers has co-founded 4 companies in which these discoveries and others have been further developed and evaluated in real-world settings, including 2 therapeutics programs that have now reached human clinical trials. Mike is no stranger to the DOM, as many of you know. He served as the division head of rheumatology for over 21 years. He has built a world-class group of clinicians, researchers, and educators in the division, many of whom are in the audience today. Mike is also a highly decorated scientist. He's given innumerable named lectures, both here in the US and overseas. He is an elected member of ASCI and AAP. And in 2024, Dr. Hollers received the ACR Presidential Gold Medal Award. This is the highest award the American College of Rheumatology can bestow and is awarded in recognition of outstanding achievements in rheumatology over an entire career. We're in for a real treat today. Please join me in welcoming Dr. Hollers for his talk entitled Rheumatoid Arthritis, New Paradigms and Opportunities in Pathogenesis, Prediction, and Prevention for the 21st Century Physician. Mike.
Thank you, Vineet. It's a very kind introduction, and I'll tell you a different story today about rheumatoid arthritis. As I was considering this presentation, what struck me is that I've been going to grand rounds for 49 years, and they've changed a lot. In the 1970s at Barnes Hospital, it was data and p-values and a lot of discussion about pathophysiology. More recently, things have evolved, and the white coat is a good example of that, sort of medicine, sociology, healthcare systems, and how you change outcomes in a larger way. So what I'm going to try to do today is something I haven't done before, and I hope it goes well, which is to integrate a number of those things. I have to show you some data, but what I want to do is emphasize where the field is going, what you can do with rheumatoid arthritis, and by extension, using these same methodologies, what one should be able to do with really any disease. So I think I need to be able to get going here. Control what? Control L. Okay. I think I'm going to let the expert do something. Control L. It's forward. Okay. Great. Okay. Thank you. We used to have these like slides that you put into something and they would fall out all the time too. So, this is nothing new for those of us who've been doing this for a while. Okay, so these are my disclosures. They're almost all related to complement as Vinit was talking about, but I certainly hope to have disclosures related to rheumatoid arthritis, and I'll get to that at the end. A number of reviews put together, Kevin Dean, for instance, and others from here that you can take a look at if you're interested. And then a number of objectives that I'd like to go through today. But the first one is to talk about rheumatoid arthritis as it really exists. There's something of a disservice when you see patients on TV with rheumatoid arthritis, because that is not the rheumatoid arthritis that people like myself and Larry Moreland saw when we were in training in the 1970s. Rheumatoid arthritis is an extraordinarily severe disease, and I think nicely and unfortunately illustrated by the case of Auguste Renoir, who in 1892 developed some signs and symptoms, and here he is in 1896 with some abnormalities in his hands. The case is of a 55-year-old male, that individual who was healthy, doing very well. He was a smoker. He developed vague joint symptoms. He worked as a painter, exposed to inhaled volatile products. No laboratories were able to be obtained, but he had swelling of his metacarpal and metatarsal joints in his hands and feet, respectively. So this is rheumatoid arthritis in the pre-treatment era. So here he is later. He's sitting because he's very immobile. He has problems in his ankles and feet, but one can start to see changes in his hands and metacarpal phalangeal joints. And here he is in 1912, wheelchair bound. Now take a look at his hands. You can see they're incredibly deformed. He had problems in his hands, feet, all large joints, and also C1, C2, where he was starting to develop erosions at that point and really unable to get up and walk around. This is him in 1915, where the paintbrush had to be put into his hand and strapped into his hand. He's in a wheelchair, and there's an extraordinary, if you ever want to see something amazing, go to this particular review. There's a linked video of him trying a painting in 1915 with this and really doing some remarkable things. And one of the amazing things to me is that in 1915, he painted this painting. So what struck me as a young trainee was that patients with severe rheumatoid arthritis at that point now in the 1970s had really remarkable deformed joints, but they were incredibly resilient, and many of them did some amazing things. And for instance, this painting is really illustrative of that. So this is a very severe disease. Now, wanted to go through the background. So this affects about 0.8 to 1% of the population. It is the second most prevalent autoimmune disease after thyroid disease. Like many autoimmune diseases, it's female predominant. First-degree relatives have a 6 to 8% risk, but the majority of cases are without a family history of rheumatoid arthritis, but many have other autoimmune diseases within their family. The synovial joints are the primary target, but as I'll show you, there are many systemic manifestations. Seropositive and seronegative. Seropositive is about 80 or 90%, and these individuals have autoantibodies that are extremely important that I'll come back to and have characterized the disease. As you could see physically in Auguste Renoir, as the disease evolves over time, the joints are destroyed. This is a classic set of x-rays. And if one looks inside the joint, you can see a little bit of erythema as it starts, but then there's new blood vessel growth and an almost pseudo-tumor-like exuberance of joint tissue expansion, and finally sclerosis and fibrosis at the end. Histologically, these are examples of rheumatoid arthritis synovium, and really show a number of, I think, very interesting features. One is this is really packed with lymphocytes and other innate cells and a lot of cells of the immune system. There's new blood vessel growth in here. There's also erosion of the bone by osteoclasts as they come into the joint. So this is what's been viewed as the primary problem is the synovium and the synovitis that develops in individuals. If you'd like a review, there's a very recent publication by two friends and colleagues, Ellen Gravelisi and Gary Firestein in the New England Journal, that really sort of go through the initiation and progression of rheumatoid arthritis, and focusing out here on the changes that I'll go through. What was striking to me, and I think encouraging to us, is that this review, for the very first time in a public audience of this scale, went through the idea that there was a pre-rheumatoid arthritis period, and actually largely based on work done here by the group that I'll go through, identified this pre-RA state and a number of the pathophysiologic features as the individuals transition to develop the synovitis. As I said, this is a systemic disease, and there are many target organs that are involved. I won't go through these in great depth, but just to say that outside of the joints, once you get rheumatoid arthritis, this is a lifelong disease. It affects a lot of different aspects of your life that I'll go through, but it also, the immune system that initially targets the joints, when it's let go, it actually continues to damage many other tissues. So this period of time has been studied extensively over the years, and there are a lot of studies focusing on the mechanism of it. And what I wanted to do with that is just focus a moment or two on the understanding of the mechanistic links between the DMARDs, the disease-modifying therapies, and the synovial cellular interactions and cytokine networks, because this really represents one of the major advances in the field, is that until around 2000, as I said, we had a very severe disease. But we were able, initially with the introduction of TNF inhibitors, and then cytokine antagonists, and finally JAK inhibitors, and other immune modulators, including B-cell depletion, to put into this immune paradigm here where you have all the cells of the immune system, essentially. We were able to understand that interrupting these various features could lead to substantial improvement, and overall, the approach to rheumatoid arthritis and patient outcomes are really very much substantially better. What I wanted to do, though, is ask a question. At this point in 2025, is the glass half full or half empty? And that is, you could argue that individuals, as I said, are much better. There are very few wheelchairs anymore. Treat to target is being explored. We're using patient outcomes in clinical trials. There are a number of very large studies, one of which I'll show you that this group has participated in. And there's a lot of data being generated and new cell populations being identified. However, there's also the other side of this, which is that individuals with treatment, the 50-25-25 rule persists. It varies a little. Some people say 60-40-20. But essentially, with every new drug class, 50% of the people get 50% better, 25% get 75% better, and the remaining 25% fail. So that basically says that we are not able to get individuals into remission. And actually, as I was looking, there are no new therapeutic classes have been successfully introduced since 2012. So that's now 13, 14 years, and there really is nothing new that patients can point to as a new therapeutic, and many individuals are now at the end of cycling through everything else. The practical experience says that if you go into remission, it's unlikely that you will be at the end of a year. Impairment of work status continues. A very recent review says that, of course, individuals are mostly from a lower socioeconomic class, and activities of daily living are still very impacted. There's a financial cost to this. And even the single-cell omics studies that I'll go through demonstrate many features, but they cross over to other diseases. So it's really unknown what is the driver of this particular autoimmune disease. So what I'm going to concentrate on, of course, is the half-empty part, because what we want to do is really focus on the things that are ongoing now to improve the outcomes. But first, I wanted to just mention, because this is work that Larry Moreland was helping to run at the University of Pittsburgh, and I was the PI at the University of Colorado. And that is one of the big omics studies that's been done. And I would highlight Fan Zhang, who's now a faculty member here, recruited to rheumatology, as the lead of this. And this is essentially omics technologies that I hope all of you have at least seen and are somewhat familiar with, in which one was able in a consortium to take synovial cells out, biopsies out, put them into single cells, and then analyze them through single cell RNA and a number of other single cell technologies. And with that approach, what Fan was able to do in leading this large consortium is to essentially take this very complicated disease and break it down into a number of subgroups that she called CTAPs. And those are subgroups that are either fibroblast rich or lymphocyte rich or myeloid cell rich. And there are some associations with poor outcomes, including those who have fibroblast rich are ones that are much less likely to respond overall to therapeutics. So this is an area that continues to expand. And the group here at the University of Colorado is playing a major role. In subsequent studies, I'll just emphasize that additional work has been done with this, but Helena Johnson, who was just recruited from the Brigham by Christy Kuhn to rheumatology, has worked with Fan, and they are continuing to look at the synovium and really work to understand unique cell populations and potential therapeutic targets that are within these populations. And I won't go any further into this because they will be able to give you some really beautiful talks about the use of omics technology in the synovium. But what I do want to do, though, is really highlight what the group here has been able to do to understand the left side of that initial paradigm, which is what happens at the beginning of disease. How do you go, like Auguste Renoir, from being a 45-year-old, extremely healthy, extremely successful individual to being a 60-year-old individual who is completely wheelchair-bound with this disease that starts in your joints and then takes over the rest of your body? So how does that occur? So in terms of how we figured out a lot of this, we now go back almost 25 years to when I first became division head in 2000. And we decided as a group to establish a study called SARA, stands for Studies of the Etiologies of Rheumatoid Arthritis. And why did we do that? Because of a number of reasons. I was a new division head. I wanted to do something new. Nobody had ever done this before. We were very frustrated at that point with the inability to really treat this disease. We didn't know nothing about the prior to the disease. We were watching cardiology introduce statins and all kinds of other approaches to prevent the onset of cardiovascular disease. There were new autoantibodies that were being generated at that point, and we were very interested in taking a high-risk, high-reward approach. And I think we'll see a number of different divisions and programs in the department and elsewhere that are taking that approach. And what I want to do is just lay out for you now what you can do with this. Of course, the first thing that we did, and Vineet pointed out, I was actually originally a mouse doctor. So we actually did a series of basic and mouse studies to demonstrate that the autoantibody responses that we're seeing were in fact pathogenic. But what I'm going to talk about today is the human data largely that lays out for you how this disease develops and our thoughts about it. The other aspect I really want to emphasize is that this is an amazing team effort. Without individuals from the University of Colorado who are here, and I'm not going to name them because I'll come back to them individually as we go through this, this is absolutely necessary to take the kind of approach that I will lay out for you. And this is not only within rheumatology as shown here, but also public health school for the epidemiology, but also working with other individuals in institutions around the United States and largely at times in the world. So this is a consortium effort, and my role today is really to tell you exactly what this group has been doing and the successes that they've had. First, though, I need to back up just a bit and talk about the autoantibodies and what they are. So we start in sort of a basic science of the process of citrullinated. So this is a process that is driven by peptidyl arginine deamidases, which are changes, post-translational changes in proteins that are found in inflammation. And these are driven by a series of enzymes. They're found ubiquitously at sites of inflammation. And this is one of those hundreds of post-translational modifications that can alter the function of intracellular and extracellular proteins, really an area that's burgeoning in the basic and translational sciences world. But what's very important about citrullinated is not the process per se, but the immune response to it, because this is the very highly specific antibody. So the antibodies, the citrullinated protein antigens, measured as anticyclic citrullinated peptide or anti-CCP. These will be used interchangeably. These are present in disease severity and poor outcomes. This was described in the late 1990s as one of the things that really opened things up for us. They are associated with genetically and how the peptides are presented. These citrullinated epitopes that I'll talk about are present in the joint, and these are pathogenic and polyreactive. And the animal studies that I laid out were some of the first to demonstrate that they are in fact pathogenic. So ACPA is what we were mostly interested in at that time. Other resources became available. One of those is the Army-Navy Serum Repository, which is something I would encourage everyone to look at and think about. So this is a serum repository that was started 25 or 30 years ago for all service members when they enter, and then periodically during their time. And around the early 2000s, we were able, with Darcy Micah, a fellow then, she and I were able to apply for the first one. These are individuals who had current rheumatoid arthritis at Walter Reed and controls, but they had stored serum samples going back years. Kevin Dean got another set of those that were even more informative. And just let me show you two things from this kind of a study. So this is the point at which these individuals developed synovitis and rheumatoid arthritis. And going back in days with this kind of approach, one could start to look at the immune response prior to clinical onset. And I would emphasize the teaching when we started this was that people were well, and then they had some exposure like a virus or something, and then within weeks or a month or two, they would develop rheumatoid arthritis. So the idea was that this was an immune response, an aberrant immune response that came at you, and then everything else happened after that. Well, what one can see here, but going back thousands of days, is that this immune response to citrullinated peptides evolved very continuously over time in individuals until they developed the disease. The other thing that was pointed out that we didn't understand then, but I think do more now, is that no single peptide reactivity was necessary nor sufficient to develop the disease. It was very heterogeneous, and the important part was to have multiple reactivities before you developed it. Kevin, as I said, went ahead, got a second set, and I think this is even more remarkable in some ways, looking at now individuals' disease here going back in time, and the green and red are the two different endotypes of individuals. Some who had early autoimmunity, some who had later, but this is 17 years prior to clinical onset. So what that means is that individuals who ultimately come in and look like Auguste Renoir have actually had a process that's been going on for well over a decade immunologically, and therefore we need to be able, if we're going to understand this disease, to find those individuals. So the question then is, how do you find them? And Kevin Dean, this is one of the really, among many accomplishments of his, but one of his major advances was really to figure out how to identify individuals in real time who had autoimmunity but did not have arthritis. And through work of himself and others in the division, we're able to determine that first-degree relatives, health fair individuals who were screened, a genetically enriched population, and increasingly individuals sent to our clinic who are antibody positive but don't have rheumatoid arthritis, is this pool of at-risk individuals that you should study and look at different subsets. And what Kevin and the group has now been able to do with this pool of individuals, which is absolutely essential, is to do natural history studies, to do a prevention trial that I'll come to at the end, and also to educate these individuals and try to understand how they do or do not want to be followed going forward. As part of the study then, we study multiple factors. And another important thing from my perspective is that we had hypotheses, but the hypotheses came from our original data. We had a very open aperture. Anybody that came to us with any idea could be collaborated with. And out of that then came sort of 4 different buckets of studies. A lot of systemic immune dysregulation, the epidemiologic factors, which I unfortunately won't have time to talk about today, the genetics, which are informative, but again, not for today, but increasingly mucosal biology. So these 2 areas that are present in this pre-RA state are the ones that we think are incredibly important in developing the disease. So another question is, how do you approach this kind of a problem? So you can test hypotheses, and I love this photo from the series that many of us have seen. You test hypotheses. So what is the hypothesis that you might have at that particular period of time that you want to test in individuals who have autoantibodies, but you don't know what's going on? They're completely asymptomatic. So what I'm going to show you, to jump ahead a little bit, are publications from 2018 and 2024 that really are the result of the studies that I'm going to talk about here. Because the hypothesis that developed out of this is that it's not one single pathway for which you develop RA. It can start in the gut, it can start in the lungs, it can start in the mouth, in the periodontum. And also there's Epstein-Barr virus, a role for Epstein-Barr virus in driving some of the B cell changes. And what we see in an at-risk population is this heterogeneous group of individuals that I'll describe to you, and subsequently you develop arthritis. So that is the hypothesis that came out of all this work, but I'll start with the lung. So why did we start with the lung? So this is work done by Kristen Demerel and Kevin Dean as her mentor when she was first a resident here and then a fellow over 10 years ago. But we knew at that point that there were several risk factors for RA if you had the disease, were inhaled or lung-related: smoking, silica, particulates, asthma, and COPD. There were a couple of case reports where individuals had elevations of ACPA and then came and developed arthritis years later. They had severe lung disease and then arthritis. That was interesting. And there was an example in the lung that you could produce rheumatoid factor and ACPA in the tissue in individuals with disease. So that was the general hypothesis. And luckily, we had an Autoimmunity Center of Excellence grant then, for which I was the PI. And the group of PIs got together and said, we want to do studies that have like a 90% chance of not working. And one of those studies was this one that Kristen and Kevin put forward, is that if you took individuals who were autoantibody positive, they had no PFT abnormalities, no lung symptoms, but if you did high-resolution CT, you might be able to see something that was present in the lungs that would maybe point you to an early cause or an early feature that might have a causal relationship. So what they were able to do, working with colleagues at National Jewish, high-resolution CTs, controls, all and never smokers, autoantibody positive cases, p-value is show that there was clearly detectable small airway disease in a large proportion of individuals who were antibody positive. And beyond that, Kristen went on to start looking at induced sputum from those individuals and demonstrated, which is to me very remarkably looking at this, again, completely asymptomatic, very activated neutrophils that are actively netting, displaying on their surface citrullinated histone H3 from these activated netting neutrophils. in individuals not only with active RA, but also at-risk individuals, and has published that in a series of really nice papers. These activated neutrophils are present in at-risk individuals, RA individuals, and also healthy controls at a much lower level. And the actual level of the nets correlates with the local production of anti-CCP3, which is the ACPA that was tested. So what that demonstrates is in a subset of individuals, not everyone, but in a subset of at-risk individuals, they have small airway disease by CT, they have activated neutrophils, they have, in other studies, cytokines and activated complement present in the lung. So that is an obvious potential driver, and Kristen continues to work on that particular area. So what about the gut? So the gut came from another kind of study about a decade ago. And again, I said open aperture. So we were collaborating with an individual at Stanford, Bill Robinson, and Bill was very interested in plasmablasts. Those are B cells that circulate. They are actually responding to antigens that you currently are being exposed to. And he had worked out beautiful techniques at that point to take individual plasmablasts and determine what the B cell receptors were recognizing and also what the isotype was. So Jen Kinslow, who was a postdoc in my lab at that time, collaborated with Bill, and we're able to demonstrate that looking at plasmablasts from these antibody-positive at-risk individuals and looking at their isotypes, they had this remarkable expansion of IgA isotype plasmablasts as compared to IgG. So what does that mean? IgA is a mucosal isotype. IgA antibodies are well known to be produced at mucosal sites and have very important defense and immune defense properties. And also, there's a literature that suggests that they could be pathogenic if they are produced in the circulation. So here we have these antibodies. And the remarkable thing was that as Bill and his group worked this through, a number of clonal families that you can see in this kind of a clonal tree, you're looking at sequences of the B cell receptors, and they're interrelated in this tree, meaning they all evolved from the same precursor. Were cross isotypes, so IgM and IgG, IgA and IgG, indicating again that this immune response was quite crossed over and might actually be reflecting in a mucosal and systemic response. And also the question was, were these ACPA producing? So now at this time, I was very fortunate to be able to recruit Christy Kuhn from Washington University, where she had actually done a postdoc in mucosal immunobiology. And she was able to take these monoclonal antibodies and working with a graduate student, Megan Criswell from the MSTP program here, was able to assess the hypothesis that these IgA, IgG cross-isotype antibodies were reacting with bacteria in the gut. What she was able to do then is show that these antibodies, most of which turned out to be ACPA antibodies, were able to pull down specific strains. And what she was able to do is isolate one particular strain. And this is now published a couple of years ago in Science Translational Medicine. But she was able, with that single strain, to demonstrate with collaborators in Seattle that that strain called isolate 7, if you took that and incubated that with T cells from RA patients from Seattle, not from Denver, but from Seattle, they would activate those cells. And it turned out that these were present in a higher proportion, and they were actually quite interesting in that they were Th17 producers. So I talked about IgA as a mucosal immunoglobulin. Th17 is a mucosal cytokine that's very much involved in responses in the mucosal sites. So really interesting set of observations. But I remember the day when Megan came in and showed me this particular picture, which was the first time that she had taken that particular strain and put it into a mouse that were monocolonized, they were germ-free, so the only bacteria they had was this particular strain, and these mice developed an inflammatory arthritis. This is the only strain that has ever been shown to be able to take a normal mouse and then to develop a rheumatoid arthritis-like picture which is associated with amazing inflammation. I showed you the human stuff. These are lymphocytes, the neutrophils, and other immune cells that are into the joint and really lead to substantial destruction. So that was another really fantastic finding. And then Jane Buckner, our collaborator at the Benaroya in Seattle, was looking at peripheral T cells and identified a particular type of T cell in individuals who were at risk that recognized a citrullinated peptide. And amazingly, they were also of this Th17 expanded isotype. So here we then had a number of different observations suggesting that there were mucosal sites involved in at-risk individuals and a particular strain, the gut and the lung. So there have done other studies with Epstein-Barr virus and with the periodontum. In the interest of time, I was not going to go through those, but just to point out that there is evidence for both of those that we've published recently, that the Epstein-Barr virus could be involved in the pre-RA period, and also periodontum may be the third mucosal site. So how did we come together to start to make this into some kind of testable hypothesis? And around this time, I became refamiliar, if you will, with this amazing book by Edward O. Wilson called Consilience. Consilience of induction. And this is how we sort of started to put together this mucosal origins hypothesis. Consilience is the principle that evidence from independent, unrelated sources can converge on strong conclusions. And it is actually something that I've done sort of naturally over the years. As a scientist, if you have an observation, the proof of it is not just to repeat that observation. The proof is to, by multiple lines of argument, be able to come to a point and say, this is where I think the problem is, or what is the mechanism that's driving it. So the consilience-based hypothesis that we came to and published in 2018 was that in normal mucosal homeostasis, we are, of course, exposed to many different microbiota. That Kristen was able to see in some individuals, these IgA ACPA in the mucosa went up and down. And we figured that that was part of normal homeostasis. If you had an infection, you wanted to clear it. However, and if you were unable to clear it by any different type of reason, you would end up then with this continuous chronic production of local ACPA and local rheumatoid factor based on either the specific nature of the bug or an immune defect that you had. And once that chronicity was set up, you were much more likely then for bacteria to transit, for you to develop an autoimmune response that would eventually target the joint. So that was the hypothesis that we have had and continue to work on. But what I wanted to do is also then come to another approach, which is increasingly being utilized in individuals with these kinds of medical and biological samples. And that is the agnostic omics approach. And I'm going to come back again to this kind of an approach. And just say that we actually have 4 ongoing omics studies that Kevin has been driving and working with various collaborators, looking at peripheral blood and doing all the same things that were done in the synovium that I showed you a bit ago. So and I'll show you one example of that, and that is done by Jun Anamo, just published in the JCI with Fan Zhang as the senior author. And that is basically to ask, if you look at at-risk individuals from this AMP, this Accelerating Medicines Partnership Program, and you look at these individuals who have disease, who are at risk and controls, and whether they're first-degree relatives or not, and you do the same kind of single-cell technologies as shown here, and ask yourself, well, what's different about individuals over time? And again, you can just put these into these U-maps with T cells and myeloid cells and B cells and NK cells. And I'll just show you the results of that, because I really do think that it's a very remarkable way to try to move the area forward and try to integrate with your hypothesis-driven work. So what Jun was able to show, and I'll just focus on this one population. So this is a T cell population, peripheral helper cells. These are helper cells for B cells. And what Fan and Jun were able to show is that in these individuals who are at risk, either first-degree relatives or not, they had a remarkable expansion of these particular TPH cells. There were other myeloid cells and other T cells and CD4 cells that were expanded, but the amazing thing to us is that this is the third study in which TPH cells or related cells, other kinds of follicular helper cells, were expanded in at-risk individuals. Both of these drive B-cell differentiation in inflamed tissues and lymph nodes, respectively, probably are very active in the tissue and synovium. And these findings suggest that they're driving the B-cell autoimmune response that is catalyzed by the initial mucosal inflammation. Some of the other cell populations one can link also, but we continue to focus on all of these populations going forward. So that is, in essence, where we are, but I'm going to sort of say, where are we? So where we are, we have the classic elephant problem right now. So you can see, I think we made amazing progress in understanding what could be going on across different populations, some longitudinal study. But we have genetics and environmental exposures. We have clinical phenotypes and transitions that Kevin has nicely characterized. We have the lung story, we have the gut story, and we have peripheral blood omics. So the question is, how do you integrate that kind of work? So this is what we hope to be our next generation, if you will, our next generation studies. A study that we call Mosaic. It's kind of a convoluted word put together. But the basic idea here is that we have, and Kevin has been able over time with these various approaches to capture individuals who are at the at-risk stage, the clinical RA stage, and who've transitioned from one point to another. We have metadata. He's generated peripheral blood samples, and we have mucosal samples from all these individuals over time. And the program project grant that we submitted in January is basically to look at the relationships between all of the mucosal sites and all the strains, looking at all the adaptive immune responses that one can measure, both to the strains as well as to citrullinated and other autoantigens, and then working with Fan and her colleagues to build a classification and prediction models that allow us to say exposure to strain A at this point leads to or is strongly associated with the development of an autoimmune response at point B, which appears to continue and we think is then related to the development of synovitis. So that's the kind of integrated, if you will, hypothesis and omics approach that we hope to be able to explore over the next couple of years as this consortium continues to work. I like the term mosaic because it does sort of remind me of a trip we took a couple of years ago, which I hope you all are able to take to Jordan. We were in the pre-war period, thankfully. And we were able to see in Madaba, there's this amazing mosaic from the 500s. And it really, this is Jerusalem, but each little piece, of course, doesn't tell you anything. But putting it all together, we end up with a beautiful rendition, if you will, of this major city. So I'm going to finish up by just sort of asking, okay, well, we've done this. So what? What about patients? What are we going to do with patients? Has there been anything done to try to prevent this disease? So I'm going to borrow from Kevin's really superb discussions of this, talking about RA prevention, the opportunities and challenges. So the conclusion is we can predict, but we cannot robustly prevent the development of RA. And there are a number of studies that have been done. I'm going to focus on two of them. But what's remarkable about this whole observation to me is that the drugs that were really instrumental, if you will, in improving the outcomes of individuals who had already developed arthritis, and that is methotrexate specifically, and also B-cell depletion, really did nothing in this pre-disease period of note. They did not prevent the onset of disease. And so that the implications of that, I think, are profound, suggesting that this whole disease process is really unique and that we need to understand it. And I'll just end by going through Kevin's really unique STOP-RA trial, which was using hydroxychloroquine. So that's one of the drugs that's approved for the treatment of rheumatoid arthritis. And for a number of reasons, this was the drug that went into the clinical trial a number of years ago under the Autoimmune Centers of Excellence that I mentioned before, and an intervention in individuals that divided into the use of hydroxychloroquine or placebo. And what's, again, remarkable is hydroxychloroquine didn't do anything, but it's incredibly important because a lot of people give hydroxychloroquine to individuals who have antibodies and maybe some symptoms, but don't have rheumatoid arthritis, because they think that it's going to prevent the disease. So this is an incredibly informative, if you will, study that says that, like everything, you need to test it, and hydroxychloroquine is not an answer. There is one drug that's provided some initial insights, and that's a drug called abatacept. And that is a drug that blocks the T-cell, B-cell collaboration that is effective in patients with active disease. And a study now done in the UK and the Netherlands was able to show, and was published last year, that a relatively short treatment with abatacept was able, in the entire population, again, these are ACPA positive individuals who don't have RA yet, was able to, at the end of the period of time, 2 years, was able to have a statistically significant effect on the development of rheumatoid arthritis. But of course, the main effect is during the treatment period, and in the whole population, once the treatment was stopped, individuals started to develop the disease again. One population was really especially interesting, and that is the population that has multiple autoantibodies. And that population is, from a number of studies, Kevin's and others, is clearly more likely to develop the disease in a shorter period of time. So this drug did have an effect, but again, it was wearing off, and this is only a smaller subset of the entire population. So we are making some progress, but we really need to identify the right drugs. So thinking about the future then, so what is the future? And our hypothesis, which we're testing, is that in order to actually treat this disease, you need to characterize the pre-RA period. You need to understand what the mucosal phenotypes are. You need to develop ways to block not only specific strains, but also the immune response that develops. That could be cytokine-based or other types of immune modulation. And hopefully, if we're able to do this, we may actually affect what is the end result of this whole process, which is the development of synovitis. And how are we doing that? Well, I have to put in a plug for my current half-time position working in CU Innovations, because CU Innovations has been developing, and I know a number of people in the audience have been talking with them, has been developing approaches to help you with large populations, with data, large data and interesting populations and interesting therapeutic targets, figure out how to move these into patient impact and not just study them in isolation. So this is what we do: disrupt status quo, challenge convention, and do breakthroughs. So if you have ideas, and I'll just open it up, I could do every time I talk about CU Innovations, I'm more than happy to talk with you about what you're doing and hook you up with this really fantastic group. So in the end then, we are in the prevention era. There's a medical need. We need to identify the right therapeutics. We need our statin equivalent, if you will. These individuals are sick. They have immune dysfunction. They've got mucosal problems. There's a lot of things going on that we can think about targeting. The endotypes may be necessary. We may need to have a lung approach, a gut approach, a periodontal approach. And the paradigm is to understand how they all fit together. And is this just true of rheumatoid arthritis? Well, I'll sort of finish with this. Every autoimmune disease that has been studied has exactly the same kind of process where individuals show up with target organ damage, and anytime you can look prior to the onset of that, what you see is that there is autoantibody production that precedes it, thyroid disease, type 1 diabetes, Sjogren's, lupus. The idea is that there are environmental triggers on top of genetic predispositions. This is called benign autoimmunity. I'm not sure I like the term, but Judith James, who's a big player in lupus, used that term. And if we can figure rheumatoid arthritis out and type 1 diabetes at the Barbara Davis Center and Public Health School, I think we can make a big impact in figuring out how to prevent autoimmune disease broadly. And with that, I'll just finish. The individuals I had mentioned individually, and also the funding of this has actually been a fascinating process because it's NIH, foundation, industry, and most recently the Allen Institute, founded by Paul Allen to study diseases like this. So an incredibly important consortium and a huge number of individuals. And with that, I'll stop. Thank you.
Mike, that was terrific. Thank you. I'm going to start with the first question maybe, which is, this all goes back to that idea back in 2002 of we need a cohort. We need to start studying the natural story of these patients. And I love the analogy with cardiology, with the Framingham and thinking through what they've learned through that. How does one even start thinking about supporting the development of a cohort? Is this NIH? Is this a combination of sources? You had a number of sites that were included initially. Talk to us more about how does that even begin to get off the ground?
Yeah, it's, I often wonder about that. Yeah. So in part, it's, you have resources. So I was a new division head, so I could focus on one area that we wanted to be uniquely recognized for. So that was part of it. We were in this period of time in which the NIH was actually going through a phase of increasing its funding, which it'll do again. So we were able, we had George Eisenbarth, who was a type 1 diabetes world-renowned expert here, who put in a grant. But in order to put that grant in, he had to have a non-type 1 diabetes disease. And he and I had been talking about rheumatoid arthritis. He asked me, what do you know about pre-RA? And I said, I don't know nothing about pre-RA. But we were able to write a grant and say, we'll study pre-RA. And that was the beginnings of the autoantibodies. And then it just built from there. So I think it's getting a team together, figuring out how to do team science, having some initial resources, and being open to different hypotheses. Because, you know, who really knew where we were going to end up back then?
Yeah, I mean, many more questions about how you can keep the patients engaged, tracking them. There's all, all the logistics.
Talk to Kevin is an expert at getting people engaged and keeping them engaged. And, you know, it's a team effort, which I can do nothing more than say that. It's an absolute team effort.
Terrific. We have a question from Dr. Haugen.
Mike, that was great. Thanks. You know, I know you don't like the term benign autoimmunity. I thought it was kind of interesting because I think that with thyroid disease, type 1 diabetes, and I'm sure with a number of the rheumatologic diseases, there are people who get those antibodies who never go on to develop the disease. And what do you think we can learn from those people?
I think we can learn a lot from them, and there's one of the populations that Kevin has put together are non-progressors to try to understand what is going on. I would say there's a fascinating observation that is challenging us to think that non-progressors have only to do with what you can see in their peripheral blood. Because if you start to look carefully, individuals who are in pre-RA, and you look at early RA once they develop synovitis, they look remarkably similar in many, many features. What that tells us is that we're either missing something, like there's an event that triggers it, triggers the target organ engagement, or we're missing something about the biomarkers and the drivers. So I think, but to me, benign autoimmunity, I just fundamentally don't like the term. There are individuals who have autoantibodies for a long time and do not develop clinical disease. Why they don't develop that is, I think, we don't understand now. It's important to study them. It's been done in type 1 diabetes, it's being done in RA, but I don't know that we're going to learn the cause of the target organ without actually getting into the target organ in a much more in-depth way. Let's see if Kevin disagrees with me. He'll yell at me later.
Mike, it was a great talk. Thanks very much. Very impressive work over the years. I was wondering, you showed a number of examples of pharmacologic interventions that failed to prevent progression of disease. What about exercise? Exercise has kind of remarkable anti-inflammatory effects and things. Is there any role for exercise, or has it been studied in the disease?
Yeah, I mean, what we can do is point to environmental exposures. So weight and smoking exposure are associated with conversion, but I'm unaware that anyone has actually done an exercise regimen to see whether it increases or decreases the rate of development.
Question from Dr. Ernest.
Yeah, great talk, Mike. So I'm going to ask you to speculate on something. So you use the statin analogy where, we block a single enzyme and have all of these beneficial outcomes for a broad group of people. And given the heterogeneity you describe in RA, if you had to predict when we're successful with preventing RA, is there going to be a single common pathway that's targeted like a statin, or do you imagine there's going to be a set of phenotypes that all are going to need a different strategy?
I would speculate that there is a common pathway that things come together, and that pathway is characterized by high titer autoantibodies and cytokines, some of which transition and some of which don't. I think if we're going to go at the root cause, I think we are unfortunately going to have to figure out what each one of these mucosal sites is doing. Part of the I think, important aspect to mosaic is that if there is one mucosal site that's necessary, so let's say the gut might be the necessary mucosal site, whatever's going on there is necessary for the other sites to actually have their effect, then I think we might be able to get to something that only targets that one area. But I think this is for the next generation or generations to figure out. But what's amazing to me is that this is now a tractable problem. I mean, seeing people like Gus Renoir, and you just sort of see this incredible destruction of joints and tissue and livelihoods, and to kind of think it comes from something that is, asymptomatic at a mucosal site is really, to me, a remarkable kind of understanding of how a disease could develop. And we actually think almost all autoimmune diseases have this kind of mucosal environmental trigger with the development of epitope spreading and molecular mimicry and a lot of things that our immune system is kind of poised to do if it gets dysregulated. So I don't know if that's a long-winded answer to say I'm not really sure, but I hope so.
When considering the role of autoantibodies in preclinical RA, how do we explain seronegative RA and tracking the development of that in individuals who are testing negative for these antibodies, autoantibodies? Okay,
that's your job going forward. Yeah, no, it is quite striking. So I think seronegative RA is probably a series of different types of arthritis that are different. They all present with joint problems. It can be severe. But one thing that Kevin did in his very first project was to take military 1 and look at cytokines in individuals who were seropositive and seronegative. And the cytokine abnormalities were not nearly as profound in the individuals who were seronegative and got rheumatoid arthritis in that longitudinal study. So I think it's a different kind of process. Probably overlaps a number of things, seronegative or spondyloarthritis, and a lot of the kind of arthritides that have other causes than this. maybe a lot of the same rules are present about what's causing damage in the tissues because the same drugs work, but I think the origins are going to be different. We just need a biomarker to find them.
Mike, we are at time. Thank you for a wonderful Grand Rounds.
Thank you.